Hello, class, and welcome to Epidemiology. In this epidemiology episode of Homelessness and Opioid Substance Abuse, Confounding Factors of a Public Health Emergency, by myself, Ruth Bittler, for the Department of Public Health, Texas A&M University Commerce, HHPH 58701W, Epidemiology with Dr. Elizabeth Washira. Let's go ahead and get started on today's episode. 1.5 million people are expected to experience homelessness each year in the United States. Displacement from stable homes is not a new phenomenon, but it is becoming more visible, especially since COVID in 2020 and the current lifting of the restrictions for social distancing. Currently, Bauer et al. 2016 reports that there are 580,000 individuals chronically living homeless. Liu and Wang 2021 and Allegrante and Sleet 2021 predict that those numbers could rise anywhere between 1.5 to 3.5 million Americans displaced from their home this year alone. But because COVID halted most of the world, those numbers could be underrepresented. There is also a crisis in this crisis. Opioid overdose is the leading cause of death amongst the homeless population, where 81% of all overdose deaths in this population is related to fentanyl and other opiates. This research does not posit that homelessness will guarantee opioid substance abuse, nor does it posit that opiate substance abuse will guarantee homelessness. However, it is postulated that the two confounding factors have strong positive cyclical correlations. Anyone can experience homelessness at any time, and the rapid increase in homelessness is increasing exposure to opiates and other open drug use, needle sharing, poor hygiene, and public defecation in placing the community health at large at risk. Chronic poor health is one of the largest contributors to homelessness. Despite extant policy and programs to attempt towards homeless prevention, Allegrante and Sleet 2021 report men, women, children, families, and veterans are regularly displaced from their homes. They chronically carry an imbalance of disease and psychosocial burdens. Liu and Wang 2021 report, quote, homeless people face intersecting physical, mental, and social burdens that greatly increase morbidity and mortality relative to the general population, end quote. In their displacement, they experience considerable stress, worsened by experience with violence, malnutrition, and several upstream causes, such as chronic poor health, poverty, extreme weather exposure to hot and cold, trauma, lack of access to health amenities, and lack of sobriety to enter into shelters and outreach centers. Downstream causes include untreated infectious diseases, heart disease, parasites from poor living conditions, and mental health disorders, increasing the likelihood of opioid use, abuse, and dependency. Methods of research for this analysis examined 23 peer-reviewed articles across multiple databases to determine the extent of opioid use among homeless populations in the United States, with corresponding interventions and recommendations. This research did not conduct an isolated empirical review study and instead presents extant literature review only and the most comprehensible current data possible due to COVID stalls. Research of analysis indicate validity to the consistent disproportionate disparity gaps, such as lack of access to healthcare, lack of resources, lack of stable finances, lack of affordable and stable recovery programs, lack of affordable housing, while other research showed opportunities for healthcare cost savings with strategic interventions that are tested in some studies. Homelessness healthcare cost burdens on emergency rooms are enormous and drive up healthcare costs, as this is the primary source of health access for the homeless. Lombardi et al. 2020 adds that from 2005 to 2015, research revealed 1.3 billion emergency room visits occurred cumulatively, where 2,750 patient encounters were homeless, and represents over 8.7 million of those visits. Additionally, when admitted for care, homeless spent an average of 6.3 days in the hospital compared to the average of 3 days for non-homeless patients. Liu and Wang 2021 posit that, quote, homeless individuals must overcome tremendous structural barriers to obtain health care, including lack of health insurance and financial difficulties, that also contend with competing priorities like securing food and shelter, which take precedence. These items, food, clothing, and shelter, are basic human rights and needs that we all deserve. Locally, Paredes 2022 in Texas PIT data or point-in-time data reports that Dallas County has an extremely high burden of homeless opioid overdose death cases, with mortality rates estimated at 14 out of 100,000 deaths and approximately 100 overdoses occurring daily, making Dallas the second highest homeless opioid overdose mortality rate amongst other urbanized cities. In 2021, Texas saw 80,000 opioid overdose deaths, where 60,000 of those deaths were male and 20,000 of those deaths were female. If we take a look at the following demographic chart, we can visually see what epidemiological descriptors are at highest risk. In Texas, the homeless population statistics are reported as 40% Hispanic or Latinx, 38% Caucasian, and 21.9% Black. Racial discrimination, congruent with social structure inequities, may be misleading, as the CDC reports COVID placed a pause on homeless field census counts. According to gender, 60.9% of the homeless population in Texas is male, 38% are female, and only 1% identify as trans, non-binary, or other. However, these numbers could be underrepresented. Age demographics in Texas come with shocking results. 76.4% of the homeless population are, of course, adults. But when you look at the children on the streets between 0 and 17 years of age, they disproportionately exceed young adults aged 18 to 24 by almost twice the state average. Most extant research cannot reach a consensus on causation or definition of homelessness. Research is greatly lacking in field studies and empirical reviews and empirical application. However, most extant research can agree that the accuracy of census reporting for homelessness and cause of death reporting for opiate overdose in this population is underserved and needs considerable improvements, positing that 80% of all overdose deaths are preventable. Additionally, a study in 2020 was conducted amongst 5,766 homeless U.S. veterans. 4.6% of those interviewed voluntarily disclosed their experience with opiate overdose within 3 years of taking the survey. And that can be seen here in this chart down here. Looking at this graph on the near-death opiate overdoses amongst the homeless veterans, unfortunately, 332 deaths or 332 lives were lost in 2020 alone. Riggs et al. 2020 reports that some research indicate these numbers are clouded by veteran suicide statistics and that accidental overdose deaths are underreported. When we compare these numbers to the city of Boston on a national scale, Boston reports 1 in 4 deaths amongst homelessness by opiates between 2013 and 2018, with a 1,400% spike in opiate use. 91% of all overdoses in Boston homeless populations were opiate-only related. The difficulty in researching accurate data may center around circumstances reported by Duran et al. In 2022, which reported synthetic opiate overdoses in Boston from 2004 to 2018 were 12 times higher than non-homeless in their state. This study suggests that homeless face regular discriminatory practices and remain marginalized without opportunities, as homeless encampments are regularly cleared by local law enforcement, and additionally posits that opiate overdose and abuse is bidirectional or confounding with homeless populations. Constant movement and encampment clearings make field studies near impossible, and it places incredible limitations and difficulties on research study applications. On a national scale, Moore 2009 report health disparity gaps of homelessness and opioid use occurs in mainly large urban cities 90% of the time, with approximately 130 overdose deaths occurring every day. Remember those Dallas statistics? Dallas has an estimated of 100 overdose cases a day. That's well over 2/3 the national daily average. It is impossible to truly mend the health gaps without acknowledging the suffrage of the homeless populations and tend to their health needs. This analysis suggests that there is room for interventions that are desperately needed to reduce this crisis in a crisis. There are two strategic implementations uncovered in this analysis that show promise. They include the MOUD/MAT, or Mobile Opioid Use Disorder Medicine Approach Treatment Units, that provide the City of Boston mobile command units with health professionals to make field contact with homeless to supply naloxone emergency kits, which is an opiate reversal drug, information and education on rehabilitation, and reduced emergency room visits by taking healthcare to the streets, increasing access to healthcare for the homeless in a geographical area. This intervention shows tremendous promise because sobriety is the first step to helping the homeless get into shelters or stable homes or to make them career ready. Less than 10% of all Americans have access to substance abuse recovery programs, which shows cultural inequities and system failures for the community at large. Extant research shows that homelessness and opioid substance abuse are confounding factors that significantly affect morbidity and mortality as a continued public health emergency. While neither is a new phenomenon, evidence-based research shows opioid overdose remains the highest cause of death amongst homeless populations across the United States. And these deaths, again, are 80% preventable. Emergent policies for permanent housing assistance with integrative health care and recovery programs is immediately necessary and the call to action, especially for the U.S. veterans, families, and children that are living on the streets. Everyone has an opportunity to raise awareness to these issues by reducing stigmas and getting involved in public outreach program initiatives. Public health majors have an opportunity to explore field research studies, employ empirical evidence-based field study analysis, promote proper census counting of the homeless, and promote proper reporting for the cause of death amongst homeless populations. Clinicians can help by asking the right questions and explaining pain management alternatives, recommending and advocating rehab while reducing prescription opiate practices. Nurses and first responders and emergency personnel can help educate the community on naloxone use, normal side effects of the drug when it's reversing a drug high, what to look for, when to call for help, and how to save their loved one. Taking action with proper intervention is a multi-level challenge and requires broad collaboration with depth and breadth to save hundreds of lives, reducing morbidity and mortality disparities amongst the homeless populations. However, inaction is dangerous, as the deep-rooted complexities of both crises are interwoven and continue to grow. Inaction leads to chronic opioid illness and injury or death, losing more lives to the war against opioids and chronic housing crisis that plague our cities. If you would like to know more about this research, you can scan the QR code here, and it will provide you a PDF copy of the poster, contact information, and a full article link as soon as it becomes available. You may also check out these resources listed here in this slideshow. Before watching this presentation, did you know or expect the number of children living on the street would be twice as high as young adults? What do you think contributes to these high numbers? Were you aware that Dallas County had such high morbidity and mortality relating to opioids in the homeless population around the city? Does this change your opinion of homeless individuals? How would you intervene? What would you do first? How would you get children away from drugs and off the streets? Would you choose to fight the homeless battle and get them into homes? Or would you choose to fight the drug battle and get drugs off the streets? Weigh in. Thank you for watching this presentation on homeless and opioid substance abuse. If you have any questions or comments, you can contact me, Ruth Fiddler, at rfiddler@leomel.tamec.edu. If you'd like to know more about the course, Epidemiology or Public Health, you can contact the course professor, Dr. Elizabeth Washira, at elizabeth.washira@tamec.edu. Thank you.